Hi, everybody. Dr. Horn with infectious disease. So today we're going to be doing MD Stewardship webinar on Intro to Antibiotic Stewardship and Wound Care. So thank you for joining. I think that, this isn't meant to be comprehensive. It's meant to be kind of the bullet points, kind of essentially foundational for, um, you know, informational for people not only in uh, not only clinical, but also, all members of the stewardship team. So including microbiology, pharmacy, if you don't have any experience with wound care, this would be a great intro to intro to antibiotic stewardship and wound care. So I'm an infectious disease doctor. I deal mainly with, the antibiotic side of it. But this is kind of an intro and the ground level antibiotics and antimicrobial stewardship and wound care. So acute and chronic wounds are different. I thought, I wanted to give some articles, if people are interested in learning more also. So this is an article, this is acute and chronic wound infections, and they differ, they differ in many ways. We'll talk about that a little bit, but generally, oftentimes when we're talking about wound infections, we're talking about acutely. So someone gets a wound, they might have a post-surgical site infection, and they might have trauma with a wound, they might have uh, been doing okay, and then all of a sudden they have cellulitis or an abscess, and oftentimes, we'll discuss what to do in those cases. Like for cellulitis, you can give 5 days for an acute cellulitis and you're good. But when it comes to chronic wounds, if someone has a wound that's been they've had for kind of a long time, it's going to be a little bit different. See, admitting people in. Okay, so acute wounds or chronic wounds, and not all wounds are infected. So when we see a wound, the first kind of question we'll have is going to be, is there an infection? Do they need antibiotics? Because antibiotics aren't always needed for all wounds, for sure. Now, these are factors influencing wound infection risk. So if you see a wound, is it infected? Is it not infected? If it's not infected, what is the likelihood of it becoming infected? Is the person at high risk or not? Or if they have repeated recurrent infections. Um, so here's, several different areas here, right? So this is on the left here, we have the microorganisms. So what's the bacteria? Is there fungus involved? When it comes to the microorganisms, so some types of bacteria are much more aggressive, can be much worse than others. So, and when it comes to microorganisms, is there a high burden of like a high bacterial load? Is it an organism that makes biofilms? What type of bacteria is there? And when we talk about the organisms that are there, we'll also talk about colonization. So just like our skin is colonized with bacteria, just like our skin is colonized, our GI tract is colonized. Our bladders can be colonized, and we can have bacteria there normally. And the idea is it's thought to be somewhat protective. So there's kind of this theory that, if you have bacteria covering the skin, it makes it harder for, a foreign bacteria to land and start to cause a problem if it's already crowded out with a bunch of other bacteria. I kind of think of it as like if you have a dense forest and you throw a seed, what's the likelihood that seed is going to, start to grow versus if there was just a fire, you just gave antibiotics and all the trees and the forest burned down, and then you throw seeds, it has the ability to grow much more easily because all the resources aren't being taken. And I think that the same way um, with the skin and with the normal flora there, because the thought is if you have like coag negative staph and you have bacteria there covering a wound, and then you give antibiotics where you get it really clean, and then like Staph aureus lands, it's much more likely to grow. So it's thought that the coag native staph and the Enterococcus and the things that are there can be protective. This thought extends also to asymptomatic bacteriuria, where you have someone that you check the urine and they have an E. coli, and that may be their normal little flora in the bladder. But they also see that if you treat that, if you give them antibiotics for asymptomatic bacteria, it actually puts them at higher risk for developing a urinary tract infection in the next couple of weeks. And that's the thought is that if you get rid of their normal flora, they're more susceptible to getting an infection from another bacteria landing and starting to cause a problem. Um, so, it's just kind of interesting. So that's the microorganisms, bacteria, fungi, and then the host. So what are the host risk factors? Are they immunosuppressed, or are they on steroids, or are they on medications that lower the immune system? Do they have a rheumatological condition where they're on something that will, a biologic or something that will suppress their immune system and make them more susceptible to getting infections? Older age, obesity, peripheral arterial disease, venous insufficiency. So blood flow is actually a really um, big factor in infections. And this is why we see foot infections so frequently, is that peripheral vascular disease, um, will lower the perfusion. And if you don't get good perfusion to those areas, then essentially your immune system can't go in and fix the problem if your immune system can't get there because the blood flow is so poor. So not only can your immune system not get there, but also the antibiotics, if you're to give antibiotics, may not be able to get there if the perfusion is poor. So in these instances, when you think of the host, whether it's overall factors or local factors, you're trying to look and see what is reversible, what is something that you can help. Hypoxia, malnutrition. So are they healthy enough to have to build protein, to have enough protein to heal their tissue there? That's often looked at as how is the albumin doing? There are some places they won't perform some surgeries if the albumin is low because they don't believe that the patient won't have the ability to heal the wound and grow new tissue and put new tissue there. And diabetes, as far as how is their sugar control? So there's microorganisms, host, and now we have wound environment. So the local factors. So there's host, there's overall host factors, and then there are local factors. And this is going to be, is there hardware involved? If there's hardware, it can be very hard to get rid of infections if there's hardware present. Oftentimes, if hardware isn't involved, we would we would say lifelong antibiotics, and that's for the life of the hardware. So if the hardware can be removed, you can often, stop antibiotics. Is there necrotic tissue involved? Necrotic tissue, if there's dead, devitalized tissue, that dead tissue works as a foreign body, right? So if you have bone there that's dead, it's then acting as a foreign body and getting in the way. Um, and then, you know, there's how is it being managed? What is happening as far as uh, how it's being um, managed as far as a clinically. Inflammation and infection in acute and hard to heal wounds. So here's, looking at the difference between acute wound infection and chronic wound infection. So this is a little bit what I was saying up front about the difference between acute and chronic wounds. Now, when you think of the causative agent, acute wounds, you have active uh, microbial cells. They're actively, continuing uh, to divide and increasing the overall bacterial load. But chronic wounds, they're more passive, right? Once that there's a high burden there, a lot of bacteria, they kind of slow down. They don't grow as much sometimes, and they're biofilm. And biofilm is an extracellular matrix that is secreted by the bacteria. So biofilms, I should include a picture of it next time. But usually when we talk about biofilms, it's kind of this uh, um, like snot-like stuff that the bacteria live in, right? So biofilms are this extracellular matrix. They kind of spit it out and live in it, and it can be very organized. And the bacteria, can have a way of you think that or I used to think that bacteria was all independent, but the bacteria there can actually communicate with each other and make a matrix and actually have ways of getting nutrients in and then waste out. I mean, biofilms are why we brush our teeth, right? So, we'll get a biofilm on our teeth and we brush it off to get rid of biofilms. It's the same as uh, bacteria that will, in streams, this why rocks are slippery. Biofilms, they're why we get our pipes at home get clogged. If you look in the uh, in the down your drain pipes and it has stuff around it, that's bacteria that's ec uh, um, extracellular matrix sticking onto things and getting stuck on stuff. And that's why, with hardware, if you have it's bacteria that can cause a biofilm that can cause it to stick and retain and stay on the hardware and makes it so it's hard to get rid of bac infections and bacteria in hardware infections. So all sorts of different types of bacteria can make biofilms, but it's usually an issue when we're talking about bacteria sticking to things like a wound or sticking to a heart valve or sticking to a port or a pick. And then the infectious process, so invasion of the host, viable tissue, and the virulence and the toxins. But chronic wounds, it's more of a biofilm that's sitting and persistent on the tissue, persistent inflammation and damage over time. Inflammatory response, this is um, the host response it's either acute, and then you have a host response that's chronic. Clinical manifestation, this is the uh, erythema, so it's red, hot, painful, and has edema, versus chronic wounds where it's wound breakdown and slow chronic over time, right? So it's just kind of different ways of thinking of a wound and bacterial damage and what is causing the damage? How acute is it versus slow and ongoing and persistent damage? So here we have acute wounds at the top. And see, these are some of the factors that we discussed. And then here we have chronic wounds down here with the biofilm, and then kind of a ongoing, you know, uh, ongoing chronic inflammation and stress there. So factors affecting wound healing. So local factors. These are the local factors we were discussing. Um, as the host, you have local factors like at the site of the wound, and then systemic factors. And generally with these, we want to look at them and see are they reversible and can we do something about it, right? So with local factors, can we improve the perfusion? If it's a foot wound, do they need a vascular stent, like a arterial stent to improve the blood flow? Patients that have, foot wounds that are chronic. We've had patients that we've given antibiotics for long periods of time and it doesn't help. Once they get a arterial stent and their infections, blood flow starts going there, you can see improvement quite quickly, right? So if the patient doesn't have pulses, the patient's perfusion is poor, you do perfusion studies and see, will it help? Because if they have a chronic wound, say on a toe, if you remove the toe, do they have enough perfusion and blood flow and um, is their nutrition well enough for them to heal? Because and this is one of the things the surgeons take into consideration because if they debride the wound or amputate a toe, if they're unable to heal there, then the question from a surgical standpoint is if they're going to do a procedure, at what level should they do the procedure where it will most likely be successful, right? So um, local factors, oxygenation, infection, foreign bodies. If there is a foreign body, sometimes if there's a wound if there's a foreign body, oftentimes what the pattern would be you're giving antibiotics and it improves and heals and gets better. Then once you stop antibiotics, you have often it's a draining sinus tract from the site of the foreign body. So if a foreign body whether they had trauma and they have something in there like splinters or stones. We've had patients that use IV drugs and use needles, and they have needles stuck in there that they don't realize. If they inject and then they immediately pass out and don't realize that the needle's still there. Um, so if there's or sutures or something that's retained material from an operation that is extremely rare now. Venous and venous insufficiency. Systemic factors. So again, you want to look at these things, go over them, and then see, is there anything that we can reverse? If there's anything that's reversible, that would be um, something to target and see if progress can be made in that area. So infection versus colonization. So as far as stewardship is concerned, this is a big deal because um, if someone has a chronic wound, it's going to grow something essentially 100% of the time. So if it's going to grow something 100% of the time, should it be swabbed or should it not be swabbed, right? So avoiding swabbing and doing cultures if possible, whenever possible. So if and whenever someone contacts me and says, "Hey, this is growing something," the question is usually going to be, well, why was it done, right? So if that goes along with pretty much any culture that's done, if they say, hey, we have a wound and it's growing this, it's like, well, also, how is the patient doing, right? Sometimes, I'll hear a lot about labs and everything, but is the patient getting better or worse? What are their symptoms? Do they have, uh, you know, s- um, pus that's coming out? Do they have discharges coming out? Do they erythema, pain, and sometimes they'll say yes, they do, or sometimes they'll say actually it looks pretty good, you know. So it- the recommendation is if they have a chronic wound, you wouldn't be doing a culture of it unless it looks grossly infected, or unless there's an underlying reason for getting the culture, right? Now, we will talk a little bit about this nerds versus stones in just a moment. So this is wound infection continuum. This is increasing microbial burden in the wound. So over here on the left, there's contamination. So microorganisms are present, but it's not proliferating. So there's some bacteria there. Colonization, where it's just essentially growing and not causing a problem. So there's no significant host reaction, no delay in wound healing. The patient's doing okay. Anytime something is not in a sterile location, um, there's going to be bacteria growing there. But is it important or not? Does it warrant antibiotics, right? So local wound infection, there's covert or overt. So if there's an infection, what are the signs of infection? And so delayed wound healing beyond expectation, increasing exudate, and then as you move to overt, you have it's red, it's warm, swelling, pus. It's just essentially getting worse and worse. Spreading infection would be extending, beyond the area, beyond just that local wound. So it's going to be invasion into the tissue. Generally, when it comes to infection, generally the best way to show that there's infection would be invasion into the tissue. So if um, an area is taken by biopsy of the tissue and then looked under the microscope, is there bacteria? Is there, a fungus there that's invading into the tissue and causing problems? And then systemic infection would be systemic signs. So fever, septic shock, so it's beyond it's either extended beyond the area and it's no longer just a local infection, or you're having just an systemic signs, which can happen even if there's a local infection. If there's some toxins that the bacteria may remain in the wound, but it may have a toxin that gets into the blood and causes problem. That would be, consistent with a toxic shock. Now, this is an acronym that I think is just something to kind of think about and can be helpful. This is suggest suggests a superficial biofilm related infection, so non-healing. This is NERDS. here, NERDS, NERDS, non-healing, exudate, increase, red, friable granulation tissue, debris, and smell, unpleasant odor. So three or greater NERDS criteria present, high likelihood of superficial infection. You can consider topical antimicrobials, consider debridement. Topical antimicrobials, it's important also not to overuse topical antimicrobials and not to use them constantly. People that use topical can also get local inflammation and irritation from topical also, something to keep in mind. Stones, deep infection indicators. So this is suggests spreading or deep tissue infection requiring systemic therapy. So the stones here. So size increasing, temperature increase. This is bone exposed or probe to bone, and we'll talk more about osteomyelitis in these situations. New areas of breakdown, erythema, extending beyond the wound margins, systemic signs, fever. So three or more stones criteria present, high likelihood of deep infection. Obtain culture and begin systemic antibiotics. So when antibiotics are not indicated, so stable, non-inflamed chronic wounds, venous stasis, dermatitis, oftentimes, we'll see this and we'll just say no antibiotics are needed. Dry, stable eschar without infection, positive cultures without symptoms. So even if it's growing something that, that has a lot of resistance, or it's growing something that, reflexively we would say it needs treatment, it's more important to look kind of at the wound, look at the patient, see how things are doing, because if there are a lot of reasons why the you know high risk for not healing, or they've had a ongoing long-term chronic infection, trying to preserve the antibiotics and not use antibiotics if it's not needed is very important. So if antibiotics are needed, going with the um, not the most broad, trying to get down to the most narrow spectrum antibiotic that will cover the bacteria that was identified is really important to try and preserve antibiotics for this person in the future. So if a patient's going to have recurrent, or you're expecting recurrent infections over time, it's really that's where antibiotic stewardship, trying to use antibiotics in a way that tries to preserve them not only for this patient, for other patients, becomes really important. Foul smell alone is common in anaerobic colonization. I think with uh, trying to keep up with wound hygiene can help with this. But oftentimes, it's for foul smell. Um, Oftentimes there's more than just that, and it's kind of sometimes can be evidence that the wound may need to be managed a little bit more closely. When antibiotics are indicated, so this is evidence of cellulitis, purulent infection with surrounding inflammation. So if it's um, you know, grossly infected, that would be the time to, take a good culture and in the correct way, which we'll talk about in a second, um, and then target what is seen there. So this is when it's grossly, you just look at it and you say that really looks infected. Systemic signs: fever, tachycardia, leukocytosis, sepsis, immunocompromised patients, or early concerning changes. Post-surgical wounds, would be at risk for getting post-surgical site infections. Now, when it comes to culture technique, I just wanted to mention it. I don't want to go into this too much. Just that there are appropriate ways to collect a culture. So not swabbing the surface. So if possible, you know, if possible, you want to clean it off as much as you can. So clean the culture after cleaning the wound. So you clean it off as much as you can, and then you want to get a deep culture. And the reason there is somewhat similar to, when you have a patient that has a chronic Foley catheter, and they come in, to the ER or clinic, and they have signs and symptoms of a urinary tract infection. The recommendation is to remove the chronic Foley, and then get urine after removing it. So you can remove it and then straight cath the person, or put a new one in and get cultures from that. And the idea there is that if you got it from the chronic Foley, you might identify a whole bunch of things, a whole bunch of bacteria that may not be important. So you may identify five things where if you take out the old one, put in a new one, and get a culture there, instead of getting five things, you might get one or two. And the idea there is that those are going to be a higher bacterial load and more relevant and more important to target. So the same idea here. So you want to clean it as much as you can, and then do this. There's a specific Levine technique for collecting cultures that is supposed to decrease the likelihood of getting bacteria that's not important and increase the likelihood of getting, only trying to identify the bacteria that is the most important to target. Um, and then as far as antibiotics, PO antibiotics are often appropriate. So you don't need IV antibiotics. You just choose antibiotics that are very bioavailable. The duration of antibiotic therapy in the absence of osteomyelitis is controversial, with risk of treatment failure balanced against the risk of resistance. So, how long should antibiotics be given for chronic wound? Now, it really depends on a lot of factors like where is the wound, what is the location, how good is the blood flow, what's been happening with the patient, uh, it's what has happened. Now, in general, as I was saying earlier, for acute soft tissue infections like cellulitis, 5 days should really be enough. Now, 5 days is enough for acute cellulitis, but you know, if you don't have if you have a patient that isn't as straightforward, like they have uh, um, a lot of issues, like their peripheral vascular disease is poor, um, excuse me, they have peripheral vascular disease. They're an uncontrolled diabetic patient. They have multiple issues. 5 days would probably not be enough. But if the what I was looking at as far as wound care, that most authors recommend 2 to 4 weeks of treatment with oral agents for infected chronic ulcers. And generally, that's what I say. I would say, it depends what's happening. How do you have cultures? Do you not have cultures? But generally, I would pick a regimen, and then I recommend uh, give antibiotics, and then at 10 to 14 days, see them reevaluate. Are they getting better? Are they getting worse? Sometimes with chronic wounds, it's hard. It might take a little bit of time to see improvements versus you know, um, a healthy person with an acute wound that I would expect improvement much faster. And generally with soft tissue infections, if they have feeling in the area, right? So if it's an area where they can feel, improvement of pain, I think is one of the things that I look at, more so than erythema. With things like cellulitis and soft tissue infections, you know, when when the bacteria um, when the bacteria burst and they lyse, that can cause inflammation. And if you that itself can cause inflammation. So one of my partners calls it bug guts. So when the bacteria lyse and all the inflammatory stuff in the inside come out, that's also, when they do studies, what they give to cause a fever. Well, they'll give parts of they'll take bacteria and kind of break it up, and then parts of the cell wall and parts of the outer membranes of the bacteria is what will cause a fever. So it's when it breaks down that sometimes it can look a little bit red, a little bit more inflamed, but pain-wise is usually improving. Now, sacral decubitus ulcers, I just wanted to mention this also, that when it comes to decubitus ulcers, like this one here, you know, um, if the bone is going to be exposed to the air, and then you wouldn't give antibiotics unless the soft tissue would cover it. Now, the reason here is that if in a case like this one, if antibiotics are given, because the bone is exposed, or a culture is taken of this, and then they're given antibiotics for 4 to 6 weeks. At the end of the 4 to 6 weeks, the bone is still exposed, and so you haven't really made progress, right? So you're not going to get rid of the osteomyelitis if it continues to be exposed. So if it continues to be exposed, um, then then not only are you not helping, but it's also you're going to kind of create resistance because sometimes these patients, if the bone continues to be exposed at the end of treatment, it's you can't sterilize the bone, and then if they leave the hospital and then they come back, well, they'll say, "Oh, the bone is exposed," and they'll want to treat again. So in these patients, really the only time to give antibiotics would be once they get good debridement and kind of scrape down to the bleeding healthy bone. Then they get a skin flap, so they'll cover it with tissue, and once they get a skin flap, then that's when you would start the clock. And so during that procedure, they would take a deep bone culture, and then when that grows out and you identify what you want to target, you can give antibiotics to target that, and then go 4 weeks and then stop, and then that would be the ideal situation, right? Now, sometimes people will get debridement, but not a skin flap, and that's essentially just digging the hole deeper, right? So if they scrape it away, then they're just exposing the deeper medullary bone to bacteria, and then it's going to get infected from there, right? And deeper in. So then later, when they're going to debride it, they'd have to scrape deeper and dig deeper. So ideally, it would all be done, in one, if not one day, ideally, if they could do it all in one procedure, that would be best for the patient. Uh, Often it won't be done until, if an ostomy needs to be done to keep stool out of the wound, or if the patient's albumin, I know some surgeons won't do it unless albumin is at least 3 to show that they can heal. There's a really good article by Brad Spellberg that's uh, to give antibiotics or not in sacral pressure ulcers. And it essentially goes through this topic extremely well. I recommend that article. Antibiotic stewardship and wound care. So this is kind of a recap. So understanding colonization versus infection, avoid unnecessary systemic antibiotics, optimize culture practice. So how to take the cultures and when to culture, select appropriate empiric therapy. So if you don't have a culture or the culture, um, if the patient needs antibiotics, acutely, what would be the empiric treatment, or if cultures are unhelpful? Generally, people have different regimens. I like to give something to cover for MRSA. Usually, I'll give doxycycline, and then something to cover, broadly. So gram negatives and anaerobes, whether that's, doxycycline plus Augmentin, or, if they, and sometimes doxycycline plus levofloxacin metronidazole, what or doxycycline plus cefpodoxime, metronidazole, something like that. And ideally, cultures, it would be um, going off of the culture results, and then if cultures are available, and also the local antibiogram, what antibiotics would be preferred at the area where the person is. Uh, and then the duration of therapy, um, which we talked about. Debridement is often more important than antibiotics. Limit topical antibiotic overuse and consider host factors and what's reversible and what you can fix and not fix. Okay. All right. So that is everything I have. Thank you everybody for joining. And if you have any questions, you can all either text me or email me or call me and ask me any questions, or and I'll make this PowerPoint available for everybody. And as always, if you have any specific questions about your patients, you can always contact us, and we'll help you with any specific patients as well. So, all right. Thank you everybody for joining.